Good afternoon, everybody. Welcome you to the monthly CME program, the first one for this year. So for the CME program in Rheumatology, we start with a presentation from Dr. Rupasinghe, Senior Registrar in Rheumatology, and her topic is Scleroderma's hidden grip impact of joint stiffness and pain. So over to you, Diniti.
Thank you, dear madam, for the kind introduction. So, good afternoon to you all. So, first, I would like to thank College of Specialists in Rheumatology and Rehabilitation for giving me this wonderful opportunity. So, the topic for today's discussion is Scleroderma's hidden grip, the impact of joint stiffness and pain. So, this is the outline of my talk today. So, moving on to our patient, who is Mr. N, 43 years old patient from Ratmalana. He's married and father of 2 children, and he was a 3-wheel driver. Presented with hyperpigmented lesions for 2 years over face, back of the neck, upper limbs, and they were progressive and also associated with skin thickening and itching of face, chest, and upper limbs as well. And also, he was complaining of difficulty in swallowing for last 6 months duration, which was gradual in onset, progressive, and it's mainly for solids and associated loss of appetite. And most recently, for last 2 months, the patient was complaining of an inflammatory type of joint pain involving bilateral wrist joints, PIP, MCP, knee joints, and the ankle joints as well. Furthermore, into his history, he has had weight loss, which is more or less subjective, because partly due to the poor intake with difficulty in swallowing, and he denied chronic cough, shortness of breath on exertion, altered bladder bowel habits, and there was no postural symptoms, hypo or hyperthyroid symptoms, and there was no history of substance abuse or over-the-counter medication use, and he has been a chronic cigarette smoker with 5-pack years, and no significant past medical history or significant family history of connective tissue disorders. He has a good family support. The functional level, he has been running his own business since the age of 20 years and was working overseas as a manual laborer. But however, due to these recent symptoms, he has left his job and has returned to Sri Lanka. And since he is the sole breadwinner of the family, he has been working as a 3-wheel driver. So moving on to examination, the patient was cachectic with a BMI of 21.8, and he was afebrile, not pale or ecteric, but thus demonstrable Raynaud's phenomenon was evident, and thus periangular capillaritis. In the facial examination of the skin, there was tightening skin causing beak nose and radial furrowing and telangiectasias, along with reduced mouth opening. And his he has had sclerodactyly, thickening and tightening of the fingers and hands extending proximally to MCP joints up to mid-upper arm. And there's evidence of speckled leukoderma and salt and pepper pigmentation with telangiectasis. So his modified Rodnan score was around 29. The musculoskeletal system examination revealed 16 tender joints, 4 swollen joints, and he was unable to make a fist. And there's on a further examination, friction rub was evident in left side wrist joint, and the proximal muscle power was 5 out of 5. His systemic examination, cardiovascular wise, he was hemodynamically stable with dual rhythm and no added sounds. The respiratory system examination, the respiratory rate was 16 with saturation 98% on air, and the symmetrical chest movements and expansion without any added sounds. Abdominal examination, the abdomen was soft and there was no palpable hepatosplenomegaly. So these are his basic investigations. According to this, his full blood count, including all 3 cell lines and liver enzymes, creatinine, UFR and the CPK was normal. But As I have highlighted here, you can see that the patient had persistently high inflammatory markers. Both ESR and the CRP has been persistently high. So we've carried out specific investigations depending on the patient's history and the examination. So the investigation-wise, the ANA was 1 in 160, and he has had a positive rheumatoid factor with 107.6, and the anti-CCP antibodies were negative. His SCL70 or else anti-topoisomerase antibodies were positive, and the androcentromere antibody was negative. The focused cardiac investigations, the ECG, there was no evidence of pulmonary hypertension. The 2D echo, no pulmonary hypertension, and he has had good biventricular functions. The further lung investigations, his chest X-ray showed hyperinflated lung fields. In the HRCT, there was evidence of COPD because he has been a chronic smoker. And the lung functions, there's mild restriction with normal DLCO levels. In the gastrointestinal wise, we have carried out an upper GI which showed antral gastritis. Along with that, we continued few other investigations as well. His HIV, hepatitis B, C, and TB screening has been negative. The serum albumin levels are 3.4 and the UPCR was 0.15. According to the ACR EULA 2013 classification criteria for scleroderma, the patient anyway on examination he has had cutaneous scleroderma extending proximal to the MCP and the MTP joints, which is a major criterion, and also he has had evidence of sclerodactyria as well. So our final diagnosis was diffuse cutaneous systemic sclerosis with skin, gastrointestinal, musculoskeletal, and Raynaud's phenomenon. The management of this patient is mainly involving an MDT approach, focusing on both pharmacological and the non-pharmacological management. The pharmacological managers was targeting the skin disease, GI involvement, musculoskeletal involvement, and the Raynaud's phenomenon. The non-pharmacological, the most importantly, we need to educate the patient and the patient counseling, and the physiotherapy and the occupational therapy, and carrying out frequent screening and monitoring at regular intervals. This slide highlights how we planned our patient's management. Since he had significant skin involvement, we already have taken the multidisciplinary involvement at this point. So the steroid local application and antihistamines and photoprotection. And we have started on MMF 1 gram twice daily, but then we have titrated the doses, but the patient could not tolerate the higher doses, so we've continued with the twice daily dose. For the Raynaud's, we've started him on nifedipine, sildenafil, and fluoxetine as well. For the inflammatory arthritis, while we were he has had severe symptoms, while the biologic screening was continuing, we've started him on HCQ. And the other options like patient education and the counseling, we've started him on proton pump inhibitors and the nutritional advisors, the physiotherapy and the occupational therapy, along with screening assessment in regular intervals. So with that, in our follow-up, the patient was having persistently these musculoskeletal symptoms with synovitis involving the PIP, MPs, and the wrist joints affecting his functional status. And he has had persistently high inflammatory markers, as I shown you before, and this severe skin disease with modified Rodnan score of 29, so which warranted aggressive treatment. So we've been the treatment, we've decided on IV rituximab, the 1 gram with 2 doses in 2 weeks apart, and while continuing his other treatment. So with that, the patient's current status after 6 weeks, his tender joint count has significantly reduced from 16 to 5, and the swollen joint count was 3, and there's a resolving tendon friction rub. And the skin score was more or less static. There's no significant progression after our interventions. And the ESR and CRP has gradually come down. It's ESR from 54 to 26 and CRP from 28 to 12. So I would like to highlight certain points why we have decided on IV rituximab at this point. The reasons were being inflammatory, because the patient has inflammatory type joint pain with the background of diffuse cutaneous sclerosis affecting his functional status. And he has had a positive rheumatoid factor, though the negative ACP antibodies. And he has had persistently high inflammatory markers, both CRP and ESR, despite the conventional DMARDs. And the presence of significant synovitis and the demonstrable tendon friction drop on examination. And there was severe or the progressive skin disease. And even though in certain guidelines, the combination of methotrexate and MMF has been recommended, but due to his severe presentation, we went ahead with IV rituximab. So it's about scleroderma. I will be discussing a few details about scleroderma in theory. So the systemic, even though the scleroderma we have the localized and the systemic parts, I will be mainly discussing about systemic sclerosis. It's a systemic autoimmune disease of unknown origin, and it's a complex and a heterogeneous disease. The women are affected 3 to 5 times more frequently than men, and it's characterized by excessive deposition of collagen and other connective tissues, macromolecules in skin and multiple internal organs. And also there's prominent and often severe proliferative alterations in the microvasculature, and there's numerous humoral and cellular immunologic abnormalities. So in this case, the genetic predisposition plays an important role. Moving into the pathophysiology, when a patient is genetically predisposed, when there's like etiologic factors or the risk factors like silicon, solvents, and radiation or radiotherapy and certain infections, it will trigger the endothelial cell and the vascular alterations leading to chronic inflammation. So with that, the activation of myofibroblasts will result in vasculopathies and tissue fibrosis, mainly involving lung, skin, heart, and the kidneys. So this, furthermore, the systemic sclerosis, we have this limited and the diffuse types. In the diffuse type, there's more diffuse skin involvement along with early aggressive involvement of the target organ involvement can be seen compared to the limited type. And this slide summarizes how the diagnosis was made, and then how we are going to classify, and depending on that, how we are going to arrange the baseline investigations, and depending on that, the initial management, follow-up assessments, and the management of established disease should be carried out. So in EULA 2023 update for scleroderma, they have given 22 recommendations considering 8 domains like Raynaud's, digital ulcers, pulmonary arterial hypertension, musculoskeletal, skin fibrosis, interstitial lung disease, GI involvement, and for the renal crisis. So out of these 8 domains, I will be focusing my discussion mainly on the musculoskeletal symptoms and its management. The musculoskeletal involvement of scleroderma, any structure of the skeleton can get affected. Like when the joints are affected, the patients the manifestations would be arthralgia, arthritis. It can be either erosive or the degenerative joint diseases. And in the tendon involvement, there would be enthesitis, tenosynovitis, and tendinitis, along with tendon friction rubs or tendon ruptures. And the bone involvement, there would be acrosteolysis, osteomyelitis. And for the soft tissues, there would be calcinosis and finger contractures. In the muscle involvements, the manifestations would be muscle pain, weakened muscle strength, and myositis. So the clinical symptoms, the patients may complain pain, swelling, stiffness, weakness, a reduced range of movements, deformities, fatigability, and reduced functional status. And the complications wise, they can get depression, anxiety, reduced quality of life, and disabilities as well. So moving on to the joint involvement in scleroderma, it's one of the commonest manifestation of the disease. Around 38 to 97% of the patients might get the joint involvement. So the commonest symptom is arthralgia, and these symptoms may precede the onset of systemic sclerosis, or it can appear together with the other manifestations as well. So it's more common in the diffuse type, and commonly the small joints of the hands get affected, and it will lead to irreversible damage. So the importance of knowing about the joint involvement, because most of the time the extensive arthritis can correlate with the disease duration, extent of skin lesions, fingertip ulcers, resorption of distal phalanx, and increased CRP levels. And apart from that, it's an independent risk factor for worsening the degree of skin involvement, occurrence of new ulcers, cardiac involvement, and further disease progression. And also it's associated with frequent development of pulmonary arterial hypertension and muscle involvement as well. The tendon involvement in scleroderma, so it's an inflammation of tendons and tendon sheaths, and tendon ruptures can occur. So the hand tendons are the most commonly affected areas, mainly the extensors, and it's also common in diffuse type. And one of the serious complications is tendon rupture, that is secondary to fibrosis in tendinitis and of the tendon sheaths. And the tears also can occur at any location. The commonest sites would be tendons of fingers, wrist, knee, ankle, and elbows. So this image shows the sites of palpable tendon friction rips. It's mainly due to the fibrin deposits on the surface of the tendon sheaths and the shoulders, elbow, wrist, knee, and ankle. So these friction rubs can be felt when moving a joint on examination. The importance of friction rubs, because it correlates with more severe cause of systemic sclerosis and the development of scleroderma renal crisis and severe GI involvement. And also it indicates rapid progression, especially in the initial phase of the disease. And it's also a risk factor for the development of fingertip ulcers, progressive skin lesions, and the development of heart failure as well. Few words about contractures are, it occurs in around 31% of patients with scleroderma, and it's most often in the second and third fingers of the hand, and it's also common in the diffuse type, and the flexion contraction of fingers are more often observed. The calcification in soft tissues and vascular changes may precede the occurrence of contractures. The importance of contractures, because it's one of the main causes of disability among these patients, and it also correlates with degree of involvement of the internal organs, specifically the GI involvement and the lung disease, and it can precede the development of scleroderma renal crisis. Acrosteolysis and calcinosis. Osteolysis of distal interphalanx, it occurs in about 20 to 40% of patients. And it includes vascular changes, hypoxia, and ischemia of distal interphalanx, and which causes bone resorption and shortening of the distal interphalanx. And this occurrence of acrosteolysis is associated with serious vascular complications like fingertip ulcers and tissue calcinosis as well. So this calcinosis further correlates with presence of acrosteolysis, telangiectasias, and fingertip ulcers with microangiopathic changes, which will be observed during the capillaroscopies. Muscle involvement, also it's known as scleroderma myopathy. The incidence would range from 5 to 96%, and the commonest symptom includes muscle weakness and the muscle pain. And myositis is observed in around 10% of patients. Out of that, the non-inflammatory myopathy is common, that is secondary to fibrosis and ischemia. And the inflammatory myopathies, about 10%, they occur more often in patients with positive anti-topoisomerase 1 antibodies. The importance is because on less than 10% of patients with scleroderma myopathy would have high CPK and aldolase levels. And also it can mainly associated in diffuse type and in male patients, and can associate with tendon friction rubs and lung volume reduction and presence of anti-topoisomerase 1 antibodies. And it shows that reduced survival due to concomitant cardiac and lung disease. The laboratory investigations that we need to carry out when a patient presents with certain musculoskeletal features, like inflammatory markers, anyway the ESR and the CRP is going to be high, and the rheumatoid factor, it present in 30% of the scleroderma patients, and also anti-citrinotic peptides, antibodies, it's around 5% of patients, they can have positive levels, and it will indicate development of erosive arthritis. Joint fluid analysis and synovial biopsies will yield features of inflammation. In radiographic findings, in the plain X-rays, they will have osteopenia, joint space narrowing and erosions. In the ultrasounds, we can carry out musculoskeletal ultrasound to detect synovitis. And the MRIs, it will show more detailed abnormalities like can assess the joint capsule, synovium, tendon and tendon sheaths in more detail. So this image shows main hand radiological patterns. In the first image, it shows erosions and the arthritis. And in the middle picture, from the arrow, it has indicated a flexion contracture. In the cornermost image, it shows the tumor calcinosis of the wrist with concomitant acrosteolysis. So the management of musculoskeletal manifestations of scleroderma, it's mainly with the kinesiotherapy and the physiotherapy. So for the non-erosive arthritis, we can try on hydroxychloroquine, methotrexate, MMF and rituximab. And even for the erosive arthritis, again HCQ, leflunomide, low dose of steroids, tocilizumab or else rituximab. And for the myositis, methotrexate and low dose of steroids. For the acrosteolysis, there's no specific treatment, but we need to treat the aggressive vasodilate therapy to improve the blood supply to the extremities. And for the fibromyalgia, we can carry out non-pharmacological and pharmacological management. For the non-pharmacological, the graded exercise programs, and pharmacological wise, duloxetine, pregabalin and TCAs. And for the calcinosis, there's no disease-modifying therapy is effective, and the treatment for the underlying Raynaud's phenomenon to improve the hypoxia and the impaired blood flow. The non-pharmacological management, it includes physiotherapy because it will strengthen the core muscles and address muscle contractures through active and passive range of movements of joints. And the aerobic exercises and resistance training, paraffin wax treatment, stretching and strengthening of hand and face exercises. So this brings to the end of my presentation. So the take-home messages that I would like to highlight is musculoskeletal involvement is common in scleroderma patients, and we need to actively evaluate these patients and treat these patients because it's an indication of more severe disease, and it can lead to serious disabilities and reduced quality of life. And the treatment is always a combination of non-pharmacological and pharmacological options. So there are only few data available on the management of musculoskeletal involvement, so the treatment should be decided depending on the other organ involvement as well. So these are my references. And also I would like to acknowledge my trainer, Dr. Duminda Abesinghe, the consultant rheumatologist from RRH, and all the consultants who involved in our patients' management, and as well as for my fellow doctors as well. Thank you.
Any questions stemming from that talk?
So after this rituximab, first congratulations, very good presentation.
Thank you.
So what happened to the speckle liquidema and tightness of the skin after rituximab infusion?
Yes, madam, more or less static. There's no
Static.
further progression because in the literature it says that after rituximab therapy, we need to follow up the patient. The more profound improvement can be seen after about 1 year duration, madam. So we need to frequently follow up the patient.
So did you continue MMF?
Yes,
after
madam.
that?
Yes.
So we have practically have seen several patients with MMF because of the thinning of the skin, the microstomia and tightness of the skin is reversed. A lot of patients we have that outcome, but that doesn't mean that stop the disease progression. But the clinical pictures and a lot of patients recover from this speckle leukodema also. Okay.
Any questions?
Yeah, thank you, Dinitha, for that good presentation. I also agree with Usha. I think the experience now we are having with MMF, not for the joint, definitely we know it doesn't work very well. Skin, in our clinics also things are getting much better. And that's probably a drug of choice for the lung involvement as well. So probably we need to start early MMF in all these patients. When they develop joints, we have a problem. Probably we need to combine, but with the immunosuppression risk is more. So thank you.
Thank you, Dr. Dinitha, for that very informative and methodical lecture. Next, we will listen to Dr. Chamara Jayatunga, who is talking to us on a very interesting topic, which is rehabilitation approach to a critically ill patient. So, Dr. Chamara Jayatunga is the consultant in rehabilitation medicine at the Ragama Rehabilitation Hospital. Over to you, Chamara.
Good afternoon, and I wish you all a happy new year. And so the topic of my talk would be rehabilitation approach to a critically ill patient, and it will be a case-based discussion. So the objectives are to give an overview of the approach and to highlight few concepts of rehab, especially for the trainees. So this is a true case, a 54-year-old male who was 54 years of age, previously fit and well, and it's a patient that I saw during my overseas training. So he cycles 10 to 15 kilometers daily, a software engineer, and he lives with a partner and no kids. So he presented to A&E with progressive lower limb weakness, and the diagnosis was Guillain-Barré syndrome. And the cause of illness was due to the ascending paralysis. He was admitted to the ICU, and he required mechanical ventilation. And then it was complicated with severe sepsis and shock. And when the patient was stable and when the neurological management was completed, he was referred for rehab. And so the question is how to approach such a patient from rehab point of view. So before that, just to remind the definition of rehabilitation, this is what is proposed by the WHO in 2021. So it's a set of interventions designed to optimize functioning. That's the keyword. And reduce disability with health condition. And there's another important keyword, interactions with their environment. So it has to be individualized. Somewhat similar, this is the British Society for Rehab, and they have given their own definition of rehab. They have put this another keyword called quality of living. Right, so the WHO is very keen on developing rehab services in the world, because they say 1 in 3 people living in the world will need some sort of rehab. Could be visual rehab due to impaired vision, hearing, balance, neurological, pediatrics, or mental health. So it's all disability. And people are living longer now with the advancement of medicine, but they are living longer with problems. So rehab is a very needy specialty. Right, so rehabilitation approach to any patient is somewhat similar. The concepts are similar. So I usually I would like to suggest a 5-step approach. So we're going to identify the disability or the problems, and then we're going to do detailed assessments. Then we'll plan goals, outcome measures, and treatment or the interventions. So certain concept or certain principles are there. So we try to go from least invasive to most invasive, but sometimes if the patient needs quick results, sometimes we might go for something invasive which gives the quickest results. So it all individualized depending on the goals. And generally we try to go for multiple if multiple treatment options are available, we would try to go one by one. But again, if we need quick results in certain conditions, we go multi-prong kind of treatment options. Right, step 1, identifying the problems. So there are so many models of disability introduced by various expert groups, but I personally prefer the WHO model, which is a biopsychosocial model. It is very easy. It just has history examination and certain investigations, but mainly the social history is key here. So it is proposed in 2001 and internationally accepted model, and it is based on biopsychosocial. So we'll try to put this model to the patient that I saw in the ICU. So, sorry, before that. So the 5 domains are affected body structure and functions, impaired activities, participation restriction. Any of these 3, if affected, that's a disability, right? But that disability depends on the environment and the personnel. Right, so we'll try to put the model to our patient. So just imagine a GBS patient that you would see in a medical ward or in ICU. So affected body structure and function, very easy. Quadriparesis, dysphagia, sialorrhea, respiratory, bladder, bowel, and mood, psychological, severe pain. And then there are potential complications. There are reduced joint range of motion because there are no voluntary movements now due to the paralysis, contracture formation, nutritional impairment, cognitive, post-ICU syndrome. So very straightforward. And then because of this, there will be impaired activities, the ADLs. And then of course, there's restriction of participation. Going to work, leisure, social. Any of these is called, if there's a problem, is a disability, right? Now, why is it important to map this? This is the basis of rehab. So this is what we are going to change, all right? I'll show you. But that disability depends on personal factors, the age, right? Same problems, GBS, elderly person versus a younger person. Race, that's because of the muscle mass and certain metabolic conditions. Gender, mainly for the bladder and the bowel, and for reproductive health. Other health conditions, quite easy to understand. The more fit you are, the more fit the rehab, or more successful the rehab would be. Coping styles, social background, education, profession, so many personal factors will alter the disability. It is not just weakness we are working with, because sometimes even by definition, there are limitations that we can. There are limitations in the disease itself that we can't change with rehab. So then we might address those things, right? Personal, and then of course the social, the barriers, financial, social. A person living in a mountainous area versus person living in coastal areas in Sri Lanka. Just imagine the amount of disability, same GBS, somebody with squatting type toilet versus somebody having commode attached bathrooms. Same weakness, same parameters neurologically. So much different. Somebody living in Sri Lanka, somebody living in another country, right? Yeah. And somebody living perhaps in a war-torn area now. So disabilities, is different. And as rehab team, we try to change whatever we can out of all those domains. So certain things, it's easy to change the type of toilet than doing expensive, futile certain exercises for longer term. It's costly, right? So that's how we want the function. Right, sorry. So this is the WHO model. So there are so many for research. You can search in the database and get for all these what I have listed here is like the ICD for diseases. There's a ICF for the function. So each of these are accepted by experts as a function in humans, right? So for example, cosmesis, that's also a function, right? For some people, that's the most concerning one. For example, a stroke patient, right? You must have seen the patients walking with the arm, curled up due to the tone. So if I'm seeing the patient, let's say after 3-4 years or maybe after 10 years, so scientifically I might not be able to get the individual movements back, but the cosmesis, the appearance, he might be able to go to work with a straighter arm, right? Yeah. So that sort of goals are still there, even we see after many years. So it's the function is the keyword. Right, so we identified the problem, but you think this is easy to identify from single consultation? No, we had to get, most of the patients that I see are like complex, so they have aphasias, not in GBS, but in ICUs, they have sepsis going, they're confused. So history taking is problematic, so we had to spend time and take repeated histories, records, give a call to the family, give a call to the previous board, so it's time consuming. That's the problem. But I try to get this picture as much as possible, that I know what are the things I can work with the team and what are the things I can't, and what are the things that we can achieve in Sri Lanka. So it's very dynamic. So this is the key in rehab, getting this picture. Right, so then we have to identify the problems in detail, right? So again, detail, the history, define the baseline functional level. So sometimes, you ask the patient, were you able to do your things alone? The answer is usually yes. But then sometimes they might be walking with handhold assistance, right? Suppose the elderly person, right? Generally people tend to give a very positive picture, which is good. But as rehab clinicians, we have to be very cautious, go to the detail and get the exact baseline functioning, right? Sometimes there was the need for a supervision, even to walk outside, right? So I would like to get a baseline detailed at functional level, because that's the first goal. Further improvements is the next step. And then there are so many assessment tools, including clinical examination, blood tests, imaging, you can do as needed. And then, of course, especially if the patient is in ICU, the topic, which is critical ill patients, so some of things we can't do, then we have to do it later. And sometimes we have to do, a doctor might not be able to do the assessments alone. They are ill. You can't position them, right? So we need teams. Maybe the critical you can do with an ICU doctor perhaps, or with the therapy team, because changing the position might affect another body system. Keep an eye. Right, so there are so many specific assessments depending on the impairments that you identified. So for muscle weakness, joint range of motion, siluria, pain, nutrition, cognition, so many problems, so many assessment tools. You can use something practicable and easily that can be done in Sri Lanka. So siluria, just remember, drooling. There are two types. One we can see, which is the drooling, which is anterior, and then there's the posterior collection, which can predispose to aspiration. One of the most disabling symptom, right? Just remember, right? Drooling is very disabling. They might not tell you, but with social stigma, and one of the disabling things. So there are drooling rating scales that we use. Right, then comes the goals. So goal is kind of a intended outcome with a specified set of interventions. So we try to set SMART goals. These can be used for our personal life as well. Specific, measurable, achievable, realistic and relevant, and timed. And the goal depends on the natural history of the disease and current medical advancements, as well as the experience of the rehab team and the patient's patient factor. So it's very individualized, right? So these are some of the goals that we set for that patient in ICU, right? The patient is still on the ventilator, so mobility-wise we are a bit restricted. So we would try to preserve the passive joint as healthy as possible, right? Because at the moment it's just the muscle weakness, but if you don't make the joints, passively mobilized, the joints will get stiffer, and that's an additional problem. And because the power will improve with that's the natural history of Guillain-Barré, right? But if the joint is got stiff, and then it's a problem. And then to preserve muscle mass as much as possible, and then to help the ICU team wean the patient from ventilation. So that's a goal in early rehab in reach to ICUs. So one of the reasons is the secretion burden. So I would like to, generally we ask from the ICU team, is the secretion a problem? In that case, if the answer is yes, usually they start treatment, the medical management. So we can help them with a bit of Botox to the salivary glands, if it's a problem only. There are other reasons why the patient needs ventilation, then there's no place for Botox, right? We can do it it's a very safe procedure. You can use a ultrasound scan and inject the parotids and submandibular. And then to prevent pressure ulcers, generally it happens, not a major goal. And the last one, this is something very important and something can be done in Sri Lanka. So tell the next of kin and the family about the next steps. So what we do here, we try to do here is just at least give them a call, right? Or get them down to the clinic and tell, right, okay, now patient is in ICU. There's a referral for rehab we have seen. And these are the current problems. And we'll try to get you to a rehab center when the patient is kind of improved, just so that there's some hope and a pathway cleared. But all realistic goals only. We shouldn't promise certain things without any scientific background. So rehab goals in the ICU, screening for cognitive impairments, if you can. But again, review the medicines, review the electrolytes, EEG, CT scan. So then only you should go for cognitive impairments. There can be certain easily reversible things, then it's a waste of time. Pain relief, very important, because pain is usually perceived by subcortical structures in the brain, right? So maybe patient is unconscious, but pain may be there, right? So go for good pain relief, because otherwise it can cause chronic pain and it is difficult to treat, and it causes mood problems. And then there are emotional components to pain. It's very difficult to do rehab. And then problematic spasticity, that is increased tone, right? So we can help the ICU team by maybe again with bit of antispastic medications and Botox. What we can do is, because you can ask the ICU nurse, do we have problematic spasticity, so that you can't, get the enough space by abducting the hips usually they are on incontinent pads, right? So the nurses can't put on the incontinent pads because the adductors are so tight, right? So then the patient will get dermatitis, pressure ulcers, even fractures as well if the patient is, in prolonged ICU care because of the manual or rupture of ligaments because of manual force to abduct. So we can give it a Botox. So those things we do as in reach. Secretion burden and psychological mood if possible. So this is how we set the goal, and this is how we generally assess the goal. It's called goal attainment scale, very simple. So we put the SMART goal like this, let's say 3 to 4 weeks to preserve passive joint range of motion. If we achieved it within 3 to 4 weeks, the attainment scale is 0. If we achieved it quicker than that, then it's +1, +2. If it took time, -1, -2, simple. Maybe not for all the goals, but for mobility and things, yes, very important. We might set a goal for somebody who is walking. Let's say I want to walk I want to make the patient get out of the bed, walk to the toilet, and do the morning bathroom routine, let's say within, 20, 30 minutes, right? And if the patient can do it, that's a 0. If the patient can do it within, let's say, 10, 15 minutes, that's a +1, +2. The patient can do it, but it takes time, then minus. Right? So that then if it's minus, you have to say why. That's the question. Is the goal wrong? Is there a medical problem? So the goal not achieving is a rehab problem. So then the rehab team has to reconsider. Right. So then comes to the outcome measures. So we identify the problem, we did detailed assessment, we set the goal. Now we need outcome measure for that particular goal. There are so many simple things from mobility, balance, Even Barthel is one of the outcome measures. For pain, you can go for visual analog scale. For balance, there are thing called Berg balance scale. And for mobility, 6-minute walking test, you can do anything. Use of these limited in the ICU, of course. Then the rehab interventions, right? Now you saw the map, 5 domains with the blue cages. It's so complex, so we need a team. One person can't usually do all. So we need a specialist to lead the team, to do the complex decision making, medical legal aspects, overall accountability, right? Coordinate with other specialties. So big role for the specialist who is looking after the patient. And then of course we need the help of other specialists, ICU team, geriatrician, rheumatologists, depending on the condition. Surgeons, doctors, yes, overall medical fitness, nurses, physios. Physios will be working with the strengthening, mobility, transferring, balance, pain relief in certain cases. Occupational therapists with the hand functions, ADLs, right? Speech and language therapists for swallowing and communication. The mental health team, very important. Whoever is available will be a very good resource person. Prosthetists and orthotists for splinting. Social service officer, nutritionist, and of course the patient and the family, right? Mind you, these patients are usually having low awareness states, so they can't give consent. So most of these decisions in ICUs are, especially the referral that we see as a rehab clinicians, are best interest decisions, right? So it's difficult, complex. It's not easy, right? Yeah, so best interest decision, just the trainees can just read how to, there are certain principles that we work with when we make a complex best interest decision. So just to show you how to preserve the passive joint range of motion, so right, correct positioning, resting splints, passive exercises. This is a proper way of maintaining the ankle range of motion, at least at 90 degrees. Otherwise, what will happen? There will be foot drop. There will be foot drop, and that's happening because of the weakness. And the joint gets, and the soft tissues get shortened, and it will take another many weeks of rehab to correct the foot drop. So better to prevent it. And then to help the ICU team to wean the patient from ventilation, so we can do these injections and the medicines. Right, so one of the goals was to make the patient able to sit in a tilt-in space wheelchair. Is somewhat complex wheelchair. Usually the ICUs have at least one. In this wheelchair for 30 to 60 minutes by 3 to 4 weeks. That's a bit of a long-term goal. But to do that, we need to kind of dissect the goal into small chunks, right? Patient has to be medically stable, pain has to be controlled, posture has to be controlled. Posture really balance can be due to orthostatic hypotension, electrolyte problems, right? Certain other medications, so postural balance. And we need to have trained people to do it. That's a problem in Sri Lanka. And then we have correct equipment. Otherwise, the patient will get additional problems. So in other countries, there are systems called hoist, right? The hoist is a mechanical way of lifting the patient and positioning in the wheelchair. So I will skip. So now we did those, set the goals, and then we had to discuss the pathway based on those serial assessments. Will the patient, depending on the impairments, will the patient need or benefit from kind of inpatient rehabilitation, or will the patient can be managed as an outpatient? Not everyone who goes to ICU will end up in specialist rehab. Some people improve. Most people improve, actually. And then can the patient go for home-based rehab? Is the patient not fit for rehab? Right? More palliative, perhaps. So we have to decide on a pathway. And the Ragama, these specialist centers are only for one set of patients, right? Who would benefit from inpatient rehab. Unfortunately, because the other pathways are not yet fully developed in the country, so we have to take for the specialist centers, but there are patients who might just need 2 weeks of maybe a bit of mobility and posture training, and then patient is back to the usual residence. So there are other pathways, but it all depends on this availability of resources, patient preference. Some people don't like, they want to go home. There are patients. and then fitness from medical and surgical point of view, prognosis, and the level of disability. So the cause of hospital admission for that particular patient, so he was weaned off from the ventilation and we took him to the specialist rehab. So that's called goal-directed specialist rehabilitation. And the next step would be again to do the 5-step assessment. So we do this, and certain body structure and functions are now, it's different now. So now he has predominantly distal upper limb weakness, right? There was small muscle wasting, hands. Proximal lower limb weakness, neuropathic pain, small muscle weakness in both hands. There was a claw hand deformity. Bilateral reduced active shoulder joint range of motion. One was due to weakness, the other one was due to adhesive capsulitis. Right? So the treatment is totally different. Deconditioning, fatigue, bladder, bowel, anxiety, lack of confidence. So these were the problems identified now once discharged from rehab, from ICU. So the problems, again, transferring, dressing, basic ADLs. Now he used to be an avid cyclist and who worked as a software engineer working from home. So using the mobile phone, signing and driving were problems now. And the personal factors were the same. Again, we need to do a detailed history examination. Now we can do thorough examinations. Patient is in the ward. Mental health, we have to assess now. Home, kitchen, toilet, entrance, barriers. And we try to come up with a new plan now with the team. And just remember about this one, special rehab concerns after critical illness. So one is the cognitive impairment, deconditioning, fatigue, and neuromuscular weakness related to critical illness, and mental health concerns, very common. So it's called post-intensive care syndrome, very common, right? They say, I think after 48 hours also you can develop milder forms of post-ICU care syndrome. So what are the goals now? Trans independently with use of an aid by 6 weeks. So because realistically, this is what we thought that would be possible, right? With an aid to walk by 6 weeks. To be able to use a self-propelled manual wheelchair for long distance. He was a cyclist, but scientifically and what we can give with therapies, realistically, this is the goal. Long distance on a wheelchair, but self-propelling. He lives with a partner, but the goal was for self-propelling. To be able to walk indoors on flat surfaces with a suitable walking aid without supervision in 6 weeks. So indoor independent, without supervision, outdoor use long manual wheelchair. And then to achieve independent basic ADLs by 6 to 8 weeks, to achieve swallowing skills. He was an NG when he came to the ward by 4 weeks. So we set the goals. And all goals have to be discussed with the patient and come to an agreement. Again, we need the full team. And again, they all have their own specific roles as well as overlapping roles. So the physios will be looking at the transferring skills, strengthening, right? Balance, and of course, patient and the family. One more thing I wanted to highlight, especially for the trainees. So there are certain services available in the country, and this funding, I think, comes from the Department of Social Services. So this is called, so you can ask or you can delegate it to one of the nurses perhaps, or to one of the junior doctors, so that just give a call to the social worker, right? So it says there's already certain allowances are happening in Sri Lanka, right? So it says disability allowance, which is 7,500 now per month, and then home modification, accessibility, modifications for accessibility, right? Change in toilet type. So there are certain allowances happening. So why not just give a call, right? And then the functional outcome after 12 weeks, he was able to trans independently. He was able to walk indoors with the elbow crutch without supervision. Was able to use a self-propelling wheelchair for longer distances. He was on normal diet and fluids, bladder and bowel continent. Neuropathic pain largely controlled, but not fully, because he developed tolerance to GABAergic medication. So only low doses of pregabalin he could tolerate. His right shoulder active range of motion improved with a bit of steroids because it was predominantly adhesive capsulitis. But the left side was muscle wasting, so there were residual problems. And then bilateral claw hand deformity persisted because lack of muscles in the small muscles, lack of or loss of muscle bulk. But he was able to operate a mobile phone and a laptop. It was slow, but that's what we could achieve. And the discharge destination was home with certain modification, no need of carers or anything. And then we would arrange the follow-up. So follow-up will be 2, ideally there should be 3 follow-up for this patient, 1 with the neurologist, 1 with the rehab medical team, the doctor or the consultant, and then therapy follow-ups, which is the frequencies you can read about in the other countries, right? Yeah, they're not very frequent. All right. Take-home messages. So maintaining good coordination and communication with the ICU and the rehab team is very essential, and it will help to achieve good functional recovery. Generally, what I'm trying to suggest is an early rehab-friendly ICU culture. Generally, it happens very well because the ICU team, they put a lot of effort to save these lives, so they would like to see them improve functionally as well. So the problem is mainly with the time and the resources, but sometimes we can coordinate things even over the phone. So that's one message. And then we try to use the WHO ICF model to identify the problems and the areas that we can work to rectify the problems. And then, of course, always it's goal-directed rehab, what we try to introduce, because just having a bed doesn't mean the patient should come there as a rehab, like an exit strategy. Patients should come to rehab beds, only a limited number available, specialist-led rehab beds, so they should come only for SMART goals. And rehab services best delivered with MDT inputs, of course. And I'd like to acknowledge all my teachers and my patients and my other references, and thank you for your attention.